Welcome, everyone. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. I'll drop the link in the chat, but it will be made available on the Blum Center website at massgeneral.org/Blum-Center. For our Zoom participants, please note that everyone is in listen-only mode. Everyone has been music here at guest speakers today. If you have any questions for our guest speakers, for our Zoom participants, feel free to enter them in the chat. And for everyone in the room today, we'll have time for them at the end. Feel free to just raise your hands and we'll alternate with questions between our in-room participants as well as Zoom. Please do not share any personal medical information or questions. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, please do complete a survey as your feedback is important to us as we plan future programs. All right, so next, it is my pleasure to welcome you all to Michelle Monahan and Kayla Northam. Michelle is a family nurse practitioner specializing in obesity medicine and bariatric surgery. She joined MGH in 2023 to create a collaborative clinic between the Weight Center and Transplant, which opened last year, called Frontier. That stands for Frailty, Obesity, and Nutrition in Transplant. Michelle helps individuals living with obesity optimize their weight and health to prepare for transplant and improve their health long after transplant. Michelle also supports bariatric surgery clinics by providing anti-obesity medication support to patients after bariatric surgery. Kayla joined the MGH Weight Center in 2023 as their first nurse practitioner specializing in obesity medicine. Her passion for obesity management combined with her background in gastroenterology has been instrumental in helping patients successfully initiate and maintain GLP-1 injection therapies. Beyond the clinic, Kayla actively advocates for the field of obesity medicine by co-authoring journal articles, participating in interviews with local media, serving as a lead resource for other advanced practice providers, and educating both patients and healthcare professionals to improve access to these life-saving medications. They are here today to give a talk on the health benefits of GLP-1 injection. So please join me in welcoming Michelle and Kayla.
Thank you so much for the introduction, and thank you all for being here today. These Blum Center programs are your opportunity to learn about topics that you feel are important and to be advocates in your health. And we are just so honored and privileged to be part of that discussion for you. So thank you for being here. The emphasis of today's talk is on injectable medications, but it is important to know that they are just one tool in the toolbox. Ultimately, we hope that by the end of this talk, we'll be able to supply you with the facts and knowledge that you need to be able to access treatments and feel confident in your treatment plans. We will start by sharing how we define and diagnose obesity and what the complications of untreated obesity are. We'll then talk more about the GLP-1 injections for obesity and what health habits we can use to support these therapies. We will end with some GLP-1 myths we might see on social media and in the news so that you are well informed. So what is obesity? Obesity is a chronic disease that causes a buildup of excess fat in the body, and that can cause harm to other organs and body systems. This includes the heart, the lungs, the brain, the liver, joints, and more. Now, fat is an essential tissue in the body. It protects the organs. It provides cushioning for the internal organs and provides a buffer from external temperatures. It's a really busy and talkative organ, supporting metabolism or how we use food for energy and making hormones. Everyone needs fat in the body, but sometimes fat grows to a dysfunctional level where it doesn't work properly. We see evidence of this when movement becomes really difficult because of pressure on the joint. We might see abnormal lab values like high sugars or abnormal cholesterol levels, rises in blood pressure. And we see that people develop other diseases that are co-occurring. Obesity is very complex. There are many causes. Genetics play a small role. These are the features that we inherit from our parents, from our grandparents, and they're influenced by our environment, the air we breathe, the food we eat, our relationships and stress level. This is called epigenetics. Behaviors like the food we eat, activity levels, substance use, and sleep patterns are often influenced by external factors like accessing healthy foods and outdoor spaces. And internal factors like mood changes and stress can also contribute to weight gain. Some medical conditions cause weight gain, and this might include some hormonal changes, and some medications cause weight gain as a side effect. Hardly ever do Kayla and I see patients in clinic that only have one cause of obesity. And these causes can't easily be changed. Therefore, a successful treatment can be very challenging. We diagnose obesity on the presence of increased body fat. The first number we look at is a BMI. BMI is the relationship between your height and your weight and attempts to define the average body size. So when we see a high BMI, we can assume that somebody might be living in a larger body, but that doesn't tell us what that larger body is made of. Is it fat tissue? Is it water? Is it muscle? When we see a BMI over 40, that is usually consistent with a diagnosis of obesity. It is consistent with the diagnosis of obesity, but less than 40, we might want to start looking at some additional measures like taking waist circumference. That's an area where people tend to hold on to excess fat that causes ill health consequences. So that's a really helpful measurement. We can also measure direct fat by using body composition scales and DEXA scans. Though these technologies are expensive, DEXA scans use radiation, so we don't use them in clinics. For most people, that waist circumference and a clinical eye-in conversation is sufficient to make a diagnosis. It is important that those body measurements might vary from people of different race or ethnic groups. So it's very important that your measurements are being compared to people of your race or ethnicity. The next step is to determine if there are any weight-related conditions present. These are often complications of obesity and affect nearly every organ in the body. Conditions like diabetes, metabolic liver disease or fatty liver, high blood pressure, heart disease, and sleep apnea are some. Often these conditions are present and people are being treated for them, but the obesity is not always being treated. And so the worsening of the blood pressure and of the diabetes, those diseases worsen if the obesity is left untreated. So it's really important to be looking at the presence of that excess fat when you're treating your other health problems. So how do we treat obesity? When we talk about treatment, people love to set a certain weight goal. I want to weigh this much, or I want to lose this much. For folks that do have an obesity-related condition, like diabetes or heart disease, what is that amount of weight that actually benefits your health? We use an estimation based on percent body fat. So I'm going to use a person who weighs 300 pounds to illustrate this. That percentage is for every patient, but that amount of weight is going to be different depending on what size your body is. So if you have diabetes, to put diabetes into remission, we're looking at 20% weight loss. So a person weighing 300 pounds would lose about 60 pounds to achieve remission of diabetes. Improvement of high blood pressure, 5 to 15% or 15 to 45 pounds. Improvement in heart disease and reduced risk of heart attack or stroke, 10 or more percent of body weight or 30 pounds. Improvement in liver disease, 5 to 15% of body weight or 15 to 30 pounds. Sleep apnea, 10% or 30 pounds. Stress incontinence of urine, 5 to 10% of body weight or 15 to 30 pounds. Osteoarthritis, pain and pressure on the joints, 5 to 10% of body weight or 15 to 30 pounds. GERD, 5 to 10% for women, 10% for men, or 15 to 30 plus pounds. And PCOS, 5 to 15% body loss, or 15 to 30 pounds. So those percentages can be applied to each person. The actual pounds lost depends on your body size, but this can be calculated based on where you are and what your goals are. Polycystic ovarian syndrome. So our treatment goals, the numbers are great. But really what we're after are these non-scale victories. We want you to achieve a certain weight loss so that your future health risks can be reduced, right? So if you have high blood pressure, if you have diabetes, we really want to see that your future risk for heart attacks and strokes are reduced. When we treat obesity appropriately, we can actually see that the amount of medications you take for your other conditions will come down. There's less need for antihypertensives, less need for diabetes medicines. We see people with sleep apnea able to come off of their masks. So we work really, really closely with your primary and your specialist to make sure that you're not just losing a number on the scale, but your other markers of health are improving. And doing that, we can improve quality of life. Not taking as many medications every day is that's a nice benefit, being able to move more comfortably and be able to do the activities that you want to do without weight holding you back. These are the things that really matter to us when we're counseling our patients and coming up with treatment goals. So, what do we have for treatment? GLP medications, like I mentioned in the beginning, are just one tool. Lifestyle and behavioral changes are recommended for every patient that uses a GLP-1 medication, and every patient that goes to bariatric surgery. The issue with lifestyle and behavioral changes alone, though, is that your body gets used to the changes that you make. And you heard that right. Your body has a set point. There's a weight it wants to be at, which is why we talk to people over and over and over again who have been trying and successful with weight loss, and then the weight came back, and then they lost weight, but not as much, and then more weight came back. Your body is holding on to a certain set point. So we often have to use more intense treatments to trick the body into finding a new weight. And we can do that with medicines and surgery. Injection medications are one of those treatments that we can use to really help change that set point. So when do we consider injectable medications? So to know when to use them, we have to understand how they work. Injectable medications are a part of a class of medicines called glucagon-like peptides. And guess what? Your body already makes it in the intestines or your guts. The problem with the GLP-1 that your body already makes, though, is that it's rapidly broken down, so it doesn't get to have an effect on the target areas of the body. So these medications were designed to make that hormone stronger and resist breakdown. So it is a hormone. Hormones job in the body is to talk to other body systems about how we use energy and what our appetite is. And that's how that GLP works. It has 3 primary sites. It tells the brain to decrease hunger and to increase fullness. That's that food noise that people describe when they're talking about hunger in obesity. It signals the stomach to slow down emptying time, so we eat less. And then lastly, and this is my favorite part, it signals the pancreas to make more insulin and make it work better. When we eat food, any food, it is broken down to the most simplest fuel, which is a sugar called glucose. In order to get that glucose to work, we need insulin. And when diabetes is not controlled or obesity is not controlled, insulin doesn't work well. So these medicines improve how much insulin we get, how well it works. And the other effect of this is that it also decreases our triglycerides, which are part of our cholesterol panel. That's a lipid that can cause heart disease. And all of these effects together, this is what's called metabolism, reduces inflammation, and we lose weight too. So we see the most improvement in cardiovascular disease is that there was a previous Blum talk specifically on GLP-1s and cardiovascular disease. And that's really when we're looking at obesity as a disease, one of the most severe or significant complications that we see are heart attacks and strokes. So the way these molecules work, or these medicines work, is they decrease inflammation on the heart and the brain. And in people who are at risk for heart disease, actually have a decreased risk for heart attacks and strokes. Similarly, sleep apnea is another condition where we see a big benefit with these medicines, reducing weight. So sleep apnea is when the tongue falls on the back of the throat and airway is obstructed when breathing. People complain of snoring and daytime fatigue. And when we use these medicines and relieve some of that excess weight on the chest and also improve complications of sleep apnea like uncontrolled sugar and cholesterol and inflammation, we can also have really significant treatment improvements and improvements in quality of life. And some people are able to minimize or come off of their sleep apnea machines, but we do this in concert with your sleep medicine doctors. So I'm going to hand this over to Kayla. She's going to talk a little bit more about these special indications and how to be successful, and we'll talk about some myths.
Thank you, Michelle. So next, we're going to talk about my personal favorite soapbox on these medications because of how expensive they are. Yeah. So injection medications, so the GLP-1s that we talk about, we have to talk about certain aspects of them. Talk about insurance. We also have to talk about who is eligible. We're not going to give these to every person who comes in if we don't have that excess body weight, that abnormal storage of fat tissue. Currently, a lot of those are based off of body mass index because it's the scale we have. So anyone with a BMI between 27 to 29.9, if you have a secondary health condition like high blood pressure, like acid reflux, like arthritis in your joints, especially in your hips and your knees, that can help you qualify for using these medications. And then anyone with a body mass index over 30 qualifies for these as well. And you don't necessarily have to have those health complications, okay? But this is healthcare in the United States. And a lot of our decisions in clinic get driven by what is your insurance going to cover. That's why we have to talk about FDA indications, okay? So FDA indications are what the medicine was studied for and approved for. And drug companies are clever. They'll take the same molecule, the same drug, they will put a new sticker on it and a new name when they're going to get a new indication, because that gets them more money and more control over this in the long run, okay? So medications that are only FDA approved for type 2 diabetes, Ozempic, Trulicity, Mounjaro, and Victoza. Insurance does not have to cover these if you do not have type 2 diabetes. They will check to see if you have type 2 diabetes. Often your provider has to submit proof that you have either a hemoglobin A1C greater than 6.5% or fasting blood glucose over 126. So you check blood sugar first thing in the morning before you eat anything if it's over 126, or anytime during the day if it's over 200, even if it's after a meal, okay? Medications that are FDA approved for treatment of excess body weight and obesity, a lot of them are the same medication, but it has a new name when it's used for this. So Saxenda is liraglutide. That is the same medicine as Victoza. Wegovy is semaglutide. That is Ozempic. Zepbound is tirzepatide. That is Mounjaro. But this is where that new sticker gets put on it. And so insurance can choose to cover these if that's part of your pharmacy benefits. Okay. This does vary very widely between individual insurance plans. Some insurance plans do not cover these at all if they have an exclusion criteria. And if you have an exclusion criteria, unfortunately, they don't have to cover it. Other FDA approvals. So some of these medications now have secondary approvals. Wegovy is one of them. Wegovy's been studied to reduce risk of heart attack and stroke in patients with obesity. But in order to get that insurance coverage, kind of like how they check to see if you have diabetes for those other medications, they will check to see if you had a heart attack or a stroke, or we have some type of imaging proving vascular disease. And then Zepbound is the most recent one to get a secondary approval for treatment of obstructive sleep apnea. It has to be moderate or severe. So if your sleep study doesn't say moderate or severe, they don't have to cover this. So getting on the weight loss injections, what's the process? All right, so first is meeting with your provider and them recognizing that you have that abnormal fat storage, that you have excess body weight, obesity, recognizing those secondary health complications. Then the two of you need to discuss and come up with your treatment plan. Are these medications right for you? There is a small list of reasons why we don't use these medications based on family history, if you know it, or your own past medical history. Then they prescribe the medication if it's appropriate. From there, this is where it goes to insurance and where the prior authorization, asking insurance permission if they will cover this medication. If it's approved, then you can go to your pharmacy once it's available and pick it up and you can get started on this. And then your primary care provider, whoever's prescribing this, is going to check in periodically to make sure this medication's a good fit, make sure you're not having any negative side effects or ways to manage them when they pop up. So what is a prior authorization? As I said, this is us obtaining permission, asking permission from your insurance company. Will they cover the cost of these drugs because of how expensive they are per month? They're usually somewhere between $1,000 to $1,500 per month at your local retail pharmacies. Buying from the drug companies themselves, they're still about $500 per month as an astronomical cost, especially when we recommend long-term use of these medications. Once you've lost the weight, that health condition, excess body weight and obesity, doesn't go away. That means it's treated, right? Similarly to someone with asthma. They're on an inhaler, they can breathe more easily. That doesn't mean they don't have asthma anymore. If I take that inhaler away, the trouble breathing is going to come back. It is the same thing with these injections. We are treating obesity. When we stop the treatment, the symptom returns. The symptom for obesity is weight gain. Right. So as I mentioned, the importance of knowing that FDA indication when you're having that conversation with your provider, if you go to them and say, hey, you know, I keep hearing that celebrities are on Ozempic and it's awesome. If you don't have type 2 diabetes, insurance doesn't have to cover Ozempic. Right? And unfortunately, because of the stigma behind obesity, a lot of it, and the cost, I'm sure, a lot of insurance policies exclude anti-obesity medications. They don't see it as a health condition that they have to cover and treat. So this is where going to your insurance company and finding out what your individual policy says is important, because I could put 100 people in a room with Blue Cross Blue Shield insurance. I could get 100 different answers as to what copays are going to be, if any of them are covered, which ones are covered. So the whole picture together for treating obesity is more than just the medication. So even once we start the medication, you still have to have those building blocks, your base habits. We want you eating balanced meals with a variety of foods, whole foods, the less processed, the better. Our focus when you are on these anti-obesity medications is on protein. The goal of that is to minimize any muscle loss. If you don't eat your protein, your body's going to eat your muscle to get it. Physical activity, movement is really important on these medications. Strength and resistance training. Again, going back to muscle, it's use it or lose it. If you're not going to use it, your body's going to get rid of it. It's not going to spend resources on that muscle. Mental health, our mental health is the base of everything we do. It drives our activity levels. It drives how we feel. There's such a powerful connection between our mind and our body. So mental health is important. So if you have any struggles, working with a mental health professional to get yourself in a good place where it's going to be easier to make some of these other changes. And then sleep hygiene is a fancy way of saying get good sleep. You want to be going to bed at consistent times, waking up at consistent times, minimizing sleep interruptions, which as a parent, only so much you can do there. Making sure you're in a comfortable, safe place as best you can. And then if you have sleep apnea, using your CPAP machine so that that isn't interrupting your sleep quality. Again, diving into nutrition is such an important aspect on these injections because we are what we eat. We are made up of our nutrition, focusing on whole, nutrient-dense foods. The less processed, the better as best we can. Fruits and vegetables, important for fiber, which can help control other health risks like colon cancer. Lean proteins, so not so much red meat and burgers, but fish and poultry are going to help maintain your protein intake, maintain your muscle, and staying hydrated as best you can. Water is best, but when that's not available, choosing a low sugar or no sugar option to maintain hydration. For specific support, see a registered dietitian. These are people who have studied very hard. They've undergone testing. They can help support you and they can listen to what your own individual struggles are. Maybe you live in an area where it's harder to get nutrient-dense foods. Maybe your lifestyle is hectic and making those foods is really challenging. So get the support you need, reach out. And then our favorite, we're gonna go into myth busting. We hear a lot of things about these medications on social media. Usually, there might be a kernel of truth buried in there, but it's being blown out of proportion. They want the attention. These medications are very popular. It's a hot topic. It's why you're here today. And they know they will get your attention if they throw off alarms with these medicines. So we're going to talk about some of the common ones I hear asked about in my clinic. Stomach paralysis, aka gastroparesis. These medications slow the movement of your gastrointestinal tract. We know that. It is not permanent. There is a small percentage of adults in the United States that have this condition. They don't necessarily know it. They'll start these medications, get sick, then they get tested, and then they find the condition that was there. When we stop these medications and they've had enough time to leave your body, the movement does return. This is not a permanent change. Eye strokes. This was a study that came out from our friends at Mass Eye and Ear. Also non-arteritic anterior ischemic optic neuropathy. This is a really uncommon eye condition. There might be a connection. Hasn't been studied enough yet. But what I will say, do you know what the risk factors are for this eye condition? Obesity, type 2 diabetes, some you can't control like age over 50 or smoking, sleep apnea, hypertension, aka high blood pressure, high cholesterol, right? All things that would benefit from weight loss. By having obesity, you're at higher risk for that condition at baseline. Blockage. Bowel blockage, also known as an ileus. It's a complication of constipation, right? These medications slow down the movement of your gastrointestinal tract. That's why we talk about fiber intake. That's why we talk about fluid intake. Constipation is a very manageable condition, but reaching out to your provider if you struggle with that so they can give you some more guidance on it to help prevent a more serious blockage. Pancreatic cancer is one that scares all of us, rightfully so. It's a terrible condition to have to live with. There is no increased risk of pancreatic cancer beyond the general population by being a human existing on planet Earth. However, there is a short list of reasons we will not use these medications. One of them is pancreatitis, inflammation or infection of your pancreas. If you've had that in the past, the pancreas is a really sensitive organ. Once it's been hurt once, it can get hurt again. So if you've had pancreatitis, especially multiple episodes, that health condition is what can increase risk of pancreatic cancer. So we will not use injections in people who have had a history of pancreatitis, especially if it's happened multiple times. An exception to that can be made for people who might have had gallstones. Gallstones blocking your bile duct can cause pancreatitis, but as long as we took care of the gallbladder, took care of the gallstones, that's lower risk. Thyroid cancer is one of those big ones that I see pop up a lot. When these medications were originally studied in rodents, back in the early 2000s, late 1990s, they noticed an association with a really rare type of thyroid cancer called medullary thyroid cancer. However, we are not rodents. We have less of that receptor. It is a very low risk. It is a very rare type of thyroid cancer. But if you have a known family history of that, that is something that we will not use these injections because we don't want to take that risk. It hasn't been seen in people. In the 20+ years these medications have been around, but we will not take that risk with our patients' health. So thank you everyone for listening to us talk. So we're going to give you all the opportunity to ask questions and go from there.
All right, everyone. Thank you so much. We are now opening it up for Q&A. If you don't mind, what we're going to do today is we're going to alternate between questions coming in from the room and those Zoom participants. If you have a question, raise your hand. And if you don't mind waiting till the mic comes to you to ask a question, that way our Zoom participants can hear.
Hi, thank you for your presentation. It was awesome. That's number one. I've been told that once you reach your weight, if you're on the injectable such as Zepbound, you still have to keep taking it. What is the deal with that? Because I would like to do Zepbound, but once I reach my goal weight, I would like to be able to stop it.
That's such a great question. So why do we recommend long-term use of these medications? What we've seen, both in our clinics and in research, is that the majority of adults regain the weight lost within 6 to 12 months of stopping the medicines because we're no longer treating the health condition. I describe these medicines a lot like a restaurant, right? So there's the front of the house, the things you see and feel, that's that food noise, your appetite. That's the hostess staff, right? These medications still work on the back of the house, the kitchen, on your metabolism, on your body's drive to hold on to every single calorie you take in. So if we take the treatment for that away, your body's going to want to go back to that set point you started at.
So really it would affect the appetite more than anything, because that's my issue.
It does impact appetite, but it also impacts the metabolism. Exactly.
Yeah, okay.
All right, so we have next question. We have a participant who is no longer on Zepbound. They're substituting it with Wegovy due to insurance reasons. Will this person see a difference?
Shouldn't see a difference. Depending on what dose of the Zepbound you were changed from. So the medications have the same active ingredient, the GLP. Zepbound has a second protein that gives it a little bit of a boost. So the side effect profiles are a little bit different. You might notice that semaglutide or Wegovy is a little bit more constipating than the Zepbound. We tend to see more looser stools and a little bit more side effects on semaglutide compared to Zepbound. But I think what's really important is many side effects we can manage on that base, on that backbone of a healthy diet, not skipping meals, getting adequate fluid, preventing constipation. Those are all the ways that we can keep the medicine working well. So you might notice some difference. And if you're going from a very high dose of Zepbound to Wegovy, there might be some weight change, but if you are on a lower dose of Zepbound going to Wegovy, there are some equal doses at the that crossover.
Yeah, I would say that the average expected weight loss with Zepbound is about 20 to 22% of your starting body weight, whereas with Wegovy, the average is about 13 to 15%. So this is where when you're on those higher doses, there might be some weight return when you have to switch from Zepbound to Wegovy.
Hi, good afternoon to all. And why is so hard and to lose weight when you have so many medical conditions with Ozempic?
So unfortunately, fortunately also, our bodies are driven to survive. That is our biology, right? So if we think back in history, our bodies used to have to go through periods of famine where there wasn't as much food. So when we focus more on diet and exercise only, your body's resistant to that. It's trying to hold on to every calorie you take in to save your life. Depending on the secondary health condition, it also can make your metabolism lower, make your body more resistant to diet and exercise alone, and that's where the medication can be helpful. There's also certain medications you might be on to treat those health conditions that are associated with weight gain as well. So great question, a complex one to answer though. There's so many different factors that go into weight loss and whether or not a treatment will be effective.
How you can improve that?
How you can improve that. So getting an effective therapy, like a medication, can be helpful. When it's appropriate, weight loss surgery is also an extremely effective treatment. That will be a conversation between you and your provider to see what's going to be best for you as the person.
Thank you. Thank you so much.
Another thing on Ozempic for somebody that has obesity and a lot of other health conditions is even if we don't see those big changes in weight, there still is that cardiovascular benefit. So even if you're not seeing a lot of weight loss, if your sugars are controlled, some doctors, nurse practitioners, physician assistants might keep you on that medicine because of the protective benefit. One other thing that I'll say that you can do is engaging a really big team, having a dietitian, seeing a psychologist for any mood-related eating. It's not just your doctor. We have other experts that help us treat each one of those causes so you can get the whole picture.
Thank you so much.
We have a question regarding long-term effects. Are there any studies available that study the long-term effects of these medications?
That's an awesome question. So the question is long-term impacts of being on these medications, because these medicines have become really popular in the past couple of years. They've been around for over 20 years. Yes, we have newer agents, but the original medication, Victoza, has been around since the early 2000s. So we do have people who have been on therapy that long. So we do have a good idea of over 20 years of data about safety on these medications. They are safe to continue. All of the research that's coming out shows how much they benefit the body, right? So the reduced risk of heart attack and stroke, decreased pressure on your joints and better mobility, decreased fat deposits in your liver, which decreases your chance of liver failure, improvement in your kidney health. There's even data coming out showing it can help improve breathing, inflammatory joint conditions. So all of the research coming out for longer term data shows the health benefits.
Good afternoon. My name is Deborah Wilson. I was diagnosed with lipedema, and I started with a compounded trizepatide 6 months, probably almost over 6 months ago, back in September. And once Lilly's Zepbound came out and the price was reduced, I switched over from the compounded trizepatide to Eli Lilly's Zepbound, and I've lost like 65 pounds with that. And it helped with my inflammation and also with my osteoarthritis because I'm preparing for a knee replacement. But my concern is I'm a senior citizen, and my daughter is saying, how long as a senior citizen can you stay on this medication? How will it affect my health the older that I get?
Yeah, that's a great question. So on the list of reasons we can't use these medications, personal history of pancreatitis, pregnancy, we will never use weight loss drugs in pregnancy, family history of medullary thyroid cancer, or family or personal history of multiple endocrine neoplasia syndrome type 2. Say that 10 times fast. We have patients, I personally have patients well into their 90s on these medications. I have people who don't have kidney function, who have to do dialysis on these medications. I have people who have had heart attack and stroke on these medications. Age is not a reason to stop this medicine.
Thank you. Thank you.
We have a question whether these medications can affect your teeth or oral health in any way.
That's a great question. So can these medications impact your teeth and oral health? Not directly. However, they do slow down movement of your gastrointestinal tract. That means food stays in your stomach longer. It churns more and more stomach acid. And if you still have food contents in your stomach when you lay down to bed at night and it comes back up and you have really bad acid reflux, that can impact your dental enamel.
And another on dental health with these medicines, again, they're slowing down digestion. You might not be absorbing as many nutrients. And so if you have a micronutrient deficiency, that can also affect dental health as well. So a plug for eating fiber, fruits and vegetables, maybe taking a multivitamin to protect your oral cavity as well.
So you said Mounjaro and Zeptide are the same thing, correct?
Correct.
Is it different pharmaceutical companies that are making them?
No, that's the absolute wild thing with these medications. So the question was, I talked about how tirzepatide is Mounjaro and Zepbound. They're the same drug. They even have the same doses. They're both from the same manufacturer. It is quite literally the sticker they put on the medication. And because of that, they can hold on to that patent longer and they get more money.
Okay, and then when you do the injections, I would think you'd start at a low dose, like 2.5, and then after a month go up to 5, and then does it go higher than that?
It does, yeah. So talking about the titration of these medications, how you start off on them, we always start at a baby dose. No matter which medicine it is, we start at the lowest dose possible unless you're already on one. If you're already on one, we can transition at higher doses, but it's for your safety. And it improves your tolerance of the medication, less likely to have side effects you can't tolerate. How often you change the dose will depend on how you're doing on it. Are you having any negative side effects? If you're struggling with a side effect, I'm not going to want to push you up higher because that side effect could get worse. Or if you're on a lower dose and it's working and you're losing weight, especially with Zepbound, we don't necessarily have to push higher. Now, this is where it does get into insurance yet again. They have doses they will cover for long-term use. They have doses they will not cover for long-term use. You can only stay on them for a short period of time. So with Wegovy, that short-term use is 0.25, 0.5, or 1 milligram. They want you to get up to 1.7 or 2.4. They don't have to cover the lower doses because that's that FDA indication. The FDA indication is for 2.4 milligrams. So that's their excuse because they think some people probably don't need or tolerate that higher dose. Zepbound, the long-term use doses are 5, 10, or 15. It goes up as high as 15.
Okay, so once you reach your desired weight, would you then go back down in intensity?
That's a great question. So once you're at your goal weight, do you decrease your dose? Depends on what your weight's doing. So if you come to me and say, I'm at my goal weight, but I'm still really losing weight, I think I'm going to overshoot. Yes, we would decrease your dose. However, every medicine, every dose will have a maximum impact on your body. When you reach that point, you'll hover in the same 5-pound range. So if you reach your goal weight and you're kind of hovering off anyway, that dose that got you there is your maintenance dose.
I don't know about you, but I can't predict who's going to respond to what dose. There have been people I thought are going to be very sensitive to the medicines that I have to titrate all the way up to the top dose. And there are others that I get tremendous amount of weight loss just in the first 2 doses. And so everybody has a different response. Just because your neighbor, your friend, their uncle had one response doesn't mean that's going to be your response. There's huge variability. Have you figured it out?
No, there's no. The only thing I sometimes will see is families. You share your genetics and there is a connection. If if your mother, brother, or sister responded really well to a medicine, you might, depending on which family member it is, you might have the same response. So sometimes that can tell us how you'll do, but it's not a guarantee because you only share half of your genetics with your siblings or your parents. So it depends.
And one more question, Contrave. If you've been on that for a really long time, does it lose its effectiveness?
No. Yeah. So, and this is where that front of the house, back of the house conversation comes back in. So all of these medicines, when you reach that maximum effect, you might have some appetite return, that food noise. That's your body saying, I like where I am. I want to eat more to maintain this. It doesn't mean the medicine isn't working, because the back of the house is still working even when you can't see it. It's helping keep your metabolism in check so that you can maintain the weight you've lost.
Okay. And is there anything that could help with appetite after 7 o'clock at night? Because mine goes through the roof.
Yes, but that's a conversation you have to have with your doctor to see what's going to be safe for you.
Right, so we do have some questions in the Zoom. For people who have gotten to their goal weight, their goal, are they able to get off the medicines? Are there studies about weaning off?
So that goes back to the long-term use of these medicines. Once you're at your goal weight, there are research studies that support this. The majority of adults, if we stop your medicine, the weight loss associated with that dose of that medication will return, even when diet and exercise are kept constant, because we are no longer treating the back of the house anymore. We are no longer treating the underlying metabolic issue.
And if this is something that's going to be explored, like I never recommend taking people or de-escalating maintenance doses, but for some reasons there are people that do want to explore this. Please do it with your provider. Studies show that engagement and coaching leads to better outcomes. So don't do it alone. Don't just stop it. Really talk to the person that's prescribing it and have a conversation about what's going to happen if the weight comes back on, and very quickly start the meds again, because the weight comes back on quicker than you would think.
Yeah, and what I will say is if you stop and then restart, you typically lose less weight the next time around.
Mm-hmm.
The medicine is less effective because your body adapts to that medicine. So when you start back up again, it's not going to work as well. If you lose 50 pounds the first time, you probably aren't going to lose 50 the next time.
I have to have a surgery, so I have to go off. Like my surgery's on Thursday and I take my shot on Sunday. So they're saying just stop it on Sunday, 4 days off, and then I would probably just wait until Sunday. But you just go take the same?
Yeah, so that's more gaps, right? So we will temporarily stop medications for great reasons like surgery, because these medicines slow the movement of your stomach. We don't want food in your stomach on the day you go to surgery because you can't protect your lungs anymore.
Oh, okay.
So
I was curious. I didn't know why.
Yeah. So that's the reason why is we're protecting your lungs when you're under anesthesia. As long as the gap is less than 2 or 3 weeks between injections, you can restart the same dose. And typically my recommendation, if the surgery is not on your abdomen, you can restart at the same. Yeah. If it's on your abdomen, I typically will keep people off longer because I want to know if you're having a complication after surgery. I want to know it's the surgery, not the medicine.
And the other question I had was, I keep hearing the commercials for Replenza. Is that helpful, or is that just like another gimmick of just better off drinking lots of water, fruits and vegetables?
Yeah, so there is a lot of health influencers around and they make a lot of money, a lot of money selling different supplements and things that they claim work. We don't have research that supports that.
You can't out supplement your baseline healthy habits. And so if it sounds too good to be true, if it's a magic bullet, go spend your money somewhere else.
We have a question regarding side effects. Do you have any tips on managing GI side effects, including nausea?
Yeah, lots of them. So the question is, do we have tips for managing GI side effects, especially nausea? So partially depends on the agent. So some agents are going to be a little bit more likely to cause nausea than others. The GIP in Zepbound decreases the risk of nausea and acid reflux, whereas Wegovy, that can still be an issue. Make sure you're maintaining your good base habit regimen. So try to avoid very acidic foods, foods with a higher fat content. These foods leave the stomach slower for people who aren't on medicine Then we slow down the movement of your stomach when you're on it. Those foods are going to be more likely to make you queasy and sick. They sit like a rock. So red meats, greasy, oily, fried, fatty, and really high roughage foods like salad. It doesn't mean you can't have these. You just want to have them in a smaller amount earlier in the day so it has enough time to leave your stomach.
I was gonna say my general counseling is drink water, don't skip meals, and eat whole foods, fruits, vegetables, lean meats. If you do those three things, the side effects are going to be a little bit less. Another thing with nausea, though, it's a funny cousin to constipation, and these meds slow down the digestive tract. So if you're having nausea, check out what the bowels are doing. Are you having healthy bowel movements? Because it could be constipation.
It's also a funny cousin to acid reflux. So if you struggled with acid reflux before these medicines, sometimes starting an antacid can be really helpful as well.
Hi there. Thank you for the exceptional presentation. I have a question for you. So I'm kind of new in the game here, and folks over at Mass General Weight Loss Center are starting me on Trulicity. Now, I think this is one of the older.
It is.
How does that work for like weight loss? Is that one that will I would see a weight loss with?
It depends on the individual person because everyone responds to these differently, but I have seen tremendous weight loss with Trulicity. So it's absolutely worth trying because usually with Trulicity, either we're doing that because that's what your insurance will cover, or it's the gateway to potentially using other medications.
Okay, my last question is, once you reach that weight, do the insurance companies come back and argue with you to keep you on the long-term plan
Oh, that's an awesome question.
because you've reached it?
If you couldn't tell, insurance is my soapbox. So they try. However, depending on what the prior authorization is in the medication, there's starting and then there's continuing. So the starting authorization, you have to meet whatever requirements they make up. So whether that's a certain body mass index or having certain health conditions, that's starting. And that usually gives you a 6-month window to prove the medicine works. The continuing one is they want to know where you started and where you are now, and is there improvement? When the medicine's being used for weight loss, that means a 5% change from your starting body weight. For most people, that ends up being somewhere between 10 to 15 pounds. For diabetes, needs to show improvement in your hemoglobin A1C.
You have a patient that has, at their highest dosage, they've plateaued and they still haven't reached their goal weight. What advice do you have for patients?
Well, I would look at more than the goal weight too. Goal weight is nice, but what is the rest of your health doing, right? So are other conditions treated? Pre-diabetes, fatty liver disease, diabetes, high blood pressure, pain and pressure on the joints. And so that's really a conversation with medical teams, with a doctor or a nurse practitioner, PA. We can add medications to that. It's generally off label to do that. And there has to be a good amount of documentation around that. But weight plateaus will happen at certain doses. Again, that depends on the individual, or just if you're at the max dose and you lost that 22% total body weight loss, then that might be the new weight.
Yeah, so when there aren't those secondary health conditions to be looking at for improvement, and someone does want to try to push further, that's an office visit with your prescriber, because we can do combination pharmacotherapy, like Michelle said. The trick with that is we want insurance to pay for the expensive one. So anything we add on, you are going to be paying out of pocket for. Good news is usually what we add on is an older pill that's usually pretty cheap out of pocket, but it's something to consider.
And depending on the weight that you're plateauing at, also consider we can use medications in combination with bariatric surgery. So the indications for bariatric surgery are BMI of 35 with a weight-related medical condition, or a BMI over 40 at all. So if you're plateauing at a BMI between 35 and 40 and you have a secondary condition, you know, maybe it's a conversation to then start talking about bariatric surgery.
I'm hearing a lot
about off-label pharmacies compounding these medications and coming in at a much lower price than some of the insurance providers. And also, I just received notification that medication that I have been on is no longer going to be covered. What are some options with regard to that? Because that has me considering off-label compounding.
Yeah, well, first, I'm sorry that that's the case. It's always a devastating announcement that we get from our patients when they lose insurance coverage. So the question is about compounding drugs. So I'm going to date myself a little bit here. Anyone who remembers pirated videos, you don't necessarily get what they tell you you're getting. That's what compounding is. Black market, pirated medication. There's no oversight of it. There's no guarantee you're getting what they say you're getting. A lot of times, especially if you see, oh, there's a under the tongue version of Ozempic. That doesn't exist. That hasn't been studied. That is someone making that up in their lab. So we never recommend the use of compounded drugs. If you personally choose to take that risk, that is your personal decision. But a lot of the really serious health complications that you hear about in the news are coming from the use of compounded drugs. And the FDA has now shut down the use of compounded drugs. They are now completely illegal to be manufacturing because there's no longer a shortage. That was kind of the loophole those manufacturers were using for a while, is that there wasn't enough medicine from the companies to go around, so they could make it.
If you should have a conversation with your prescriber. Some of the oral medications can be used if appropriate. And again, looking at what those options are for bariatric surgery and the BMI. And again, making sure you have a comprehensive treatment plan too. You know, the drugs and the surgery are great, but you know, falling back on those baseline habits, healthy sleep, healthy relationships, access to food, and making sure that you're disciplined. And I don't want to assume anybody's not disciplined, because I see everybody works harder than anyone, but making sure you have those fundamentals as well.
Yeah, and there are cash pay options from these companies now. It's still astronomically expensive, so it tends to be the absolute last thing I recommend. But depending on which agent you go for, it can range anywhere from $350 to $499 per month from the company, which I find tends to be comparable to a lot of the compounding pharmacies now. And that was their response to compounding is, all right, well, we're going to sell it directly and try to make it cheaper so that we can keep making money.
And if you have an HSA card or an FSA card from your employer, you can use those funds in your HSA or your FSA to cover the cost of cash pay as well.
Is it true that Medicare won't cover these at all? Because that's what I've been told.
So that's not true, but it is only covered if there's an indication outside of obesity. So Medicare does not recognize obesity as a legitimate reason to treat it. We obviously disagree. But if you have moderate to severe obstructive sleep apnea, type 2 diabetes, or history of cardiovascular disease, they will cover in certain conditions.
So I think we have time for one more question. We have a question from a Zoom participant. Are there any studies connecting a reduced alcohol intake with taking GLP-1s?
That is a fantastic question. So the question is, are there any studies showing reduced alcohol intake, drinking less on these medications? Coming out, right? So we've seen it in clinic. I've had a lot of people who struggled with alcohol misuse who just have less drive to drink when they're on these medicines. So it is starting to be studied.
There are non-injectable medications too that are in early clinical trials looking at alcohol as a indication. So this is an area of like really robust research, and I anticipate in the next couple of years we'll be able to share more.
All right, so I think that's all that we have time for today. Thank you so much. I know we couldn't cover many of the great questions that entered in Zoom, but if we weren't able to address your questions today, feel free to talk to your care team. I also entered in the Zoom the website to view the recording. It's going to be available on the Blum Center website within, I would say, 2 to 3 weeks, and it's at massgeneral.org/Blum-Center. Thank you so much.
Thank you, everyone.